So I want you to imagine a detective. Let's call him Medlock Holmes.
Right, Medlock Holmes. I like that.
And he's been summoned to investigate this really peculiar, deeply unsettling medical paradox. You know, the patients arriving at his clinic, they aren't chasing a euphoric high.
No, no.
Right? They've never sought out a dealer. They've never bought drugs illegally.
Yeah.
We're talking about teachers, nurses, executives, retirees.
Everyday people, really.
Exactly. People who simply presented to their doctors years ago with chronic anxiety or, maybe crippling insomnia, and they followed the medical advice they were given to the absolute letter.
They took their medication exactly as prescribed.
Spot on.
Yeah.
Yet months or perhaps years later, they find themselves completely trapped. They're sitting in the clinic, and they no longer know whether they're taking the medication because they still genuinely need it or because their own nervous system has just quietly, invisibly adapted to its constant presence.
And that right there is the great clinical paradox of Chapter 11.10. I mean, psychiatry, at its core, is the study of how brain, mind, and experience interact. And crucially, how that intricate process can go wrong.
Which is exactly what we are focusing on today.
Yes. We're looking at sedative, hypnotic, or anxiolytic-related disorders through the lens of Kaplan and Sadok's comprehensive textbook of psychiatry. But we're not simply reading off a list of pills and their half-lives today.
No, we have to understand the delicate, dynamic equilibrium of the human central nervous system. Okay, let's unpack this. If we're going to solve the Medlock Holmes paradox, we have to address a massive conceptual failure in how these patients are treated.
You're talking about the conflation of dependence and addiction?
I am. It's this deeply ingrained clinical tendency to confuse neuroadaptive changes with a substance use disorder. I mean, we see patients who experience tremors or tachycardia when they try to taper their sleeping pills, and immediately someone just slaps the label addict on their chart.
Which is, quite frankly, an egregious clinical error. It really comes down to fundamentally misunderstanding the difference between a predictable physiological adaptation and, well, a severe socio-behavioral pathology.
Right, because physiologic dependence is just a biological reflex, isn't it?
Completely. It is purely neuroadaptive. If you administer a sedative hypnotic agent like a benzodiazepine continuously for a sustained period, the brain's receptor sensitivity will inevitably adjust.
The brain gets used to it.
Exactly. The patient will develop tolerance, so requiring a higher dose to achieve that original anxiolytic or hypnotic effect, and they will experience a withdrawal syndrome upon abrupt cessation. This is a biological inevitability for these compounds.
And it happens during perfectly legitimate, meticulously supervised medical treatment.
It does. It absolutely does.
So physiological dependence is essentially the body's homeostatic reflex. If you move to a high altitude, your body produces more red blood cells because the environment has less oxygen. The body is just adapting to survive the new baseline.
That altitude analogy is brilliant, actually. It's a perfect way to conceptualize physiological adaptation.
But a severe substance use disorder, as defined by the DSM-5-TR, that's an entirely different beast. That is essentially driving the car off a cliff on purpose.
Yes, because a severe substance use disorder requires a constellation of socio-behavioral changes that go far, far beyond mere tolerance and withdrawal.
Like what, exactly?
Well, we're looking for compulsive use, a profound loss of control over the substance, and crucially, continued use despite severe negative behavioral, social, or medical consequences.
Okay.
So a patient who displays no drug-seeking behavior, who doesn't escalate their dose unilaterally, and whose social and occupational functioning remains intact, they simply do not meet the criteria for a substance use disorder.
Regardless of how severe their physical withdrawal might be.
Exactly, regardless of the withdrawal.
And labeling them as such, it's not just academically lazy. It actively harms the therapeutic alliance.
Yeah.
You're stigmatizing the patient for a physiological response that the medication was explicitly designed to induce.
It creates immense iatrogenic distress. You have a patient already suffering from an anxiety disorder, and suddenly they're made to feel they have a catastrophic addiction or some moral failing.
When in reality, their brain is just performing the exact pharmacological maths we would expect.
Spot on. This is why our terminology must be razor sharp. In clinical psychiatry, we use the term misuse when referring to the administration of a drug in a manner inconsistent with accepted medical practice.
And we never use the term recreational use in this context, do we?
Never. The term recreational use carries this fundamentally inappropriate, harmless connotation.
Right. It implies a benign leisure activity.
Exactly. When a patient escalates their dose of alprazolam to induce a state of profound disinhibition or, mixes it with alcohol, there is nothing benign or recreational about it. It is dangerous pharmacological misuse.
Okay, so if we want to understand why this profound physical dependence happens, if we want to understand what the brain is actually adapting to at the microscopic level, we have to look under the hood.
We need to examine the brain's primary braking system.
Yes, we are talking about gamma-aminobutyric acid, or GABA.
GABA is the central nervous system's predominant inhibitory neurotransmitter. Under normal physiological conditions, GABA prevents excessive neuronal firing.
It's the molecular foundation of calm, basically.
Yes, the facilitator of sleep and the guardian of emotional and autonomic stability. And the compounds we are examining today, the benzodiazepines, the barbiturates, the Z drugs, they don't act in a vacuum.
They don't just replace GABA.
No, they don't replace it at all. They interface with the GABA type A receptor complex.
Let's visualize this for the clinicians listening, because the GABA receptor is not just a simple on-off switch, is it?
Far from it. It is a highly complex pentameric ligand-gated ion channel.
Okay, so we have a protein structure embedded in the neuronal membrane, made of 5 distinct subunits clustering together to form a central pore.
Right. And in the mammalian brain, the most common stoichiometry is 2 alpha subunits, 2 beta subunits, and 1 gamma subunit.
And when endogenous GABA binds to its specific recognition site on this receptor, it triggers a conformational change. The central pore opens, and chloride ions, which carry a negative charge, rush down their concentration gradient into the neuron.
And that influx of chloride hyperpolarizes the cell membrane.
Meaning it makes the inside more negative.
Exactly. If a neuron's resting membrane potential is, say, minus 70 millivolts, the influx of chloride pushes that potential further away from 0, perhaps to minus 75 millivolts.
Which means the neuron is significantly further away from the threshold required to fire an action potential. It is inhibited.
Precisely. Now, the pharmacology of benzodiazepines is exquisitely specific here. They do not bind to the GABA site.
Right, they bind to an allosteric modulatory site, specifically located at the extracellular interface between the gamma-2 subunit and an alpha subunit.
Yes, they are positive allosteric modulators, or PAMs.
Let me offer a mechanical metaphor for this, because I think it really helps cement the concept. Imagine the GABA receptor pore is a highly secure vault door, and GABA is the only legitimate key that fits the primary lock.
Okay, I'm with you.
A benzodiazepine molecule is not a skeleton key. It cannot open the vault on its own. Instead, it acts like a structural brace applied to the hinges. So when the legitimate key GABA is inserted, the brace alters the structural tension of the door, causing it to open much more frequently. But if there is no GABA present, the brace does absolutely nothing. The vault remains sealed.
That's a fantastic analogy, and the electrophysiology supports that deduction completely. Benzodiazepines increase the frequency of chloride channel opening events, but they absolutely require the presence of endogenous GABA to exert any physiological effect.
Which is an absolutely critical distinction.
It really is, because it brings us to the fundamental difference between modern benzodiazepines and the older class of sedative hypnotics, the barbiturates, drugs like phenobarbital, secobarbital, and pentobarbital.
So how do barbiturates interact with that same vault door?
Well, at low therapeutic concentrations, barbiturates act as allosteric modulators as well, though they bind to a different site frequently associated with the beta subunits.
And they increase the duration of the channel opening rather than the frequency, right?
Yes, exactly. But here is the critical, potentially lethal divergence. At high concentrations, barbiturates lose their reliance on GABA entirely. They transition from positive allosteric modulators to direct agonists.
Meaning they stop reinforcing the hinges and simply kick the vault door in themselves. They force the chloride channel open independent of the endogenous key.
Precisely. And this singular mechanistic difference explains the massive disparity in the safety profiles of these two drug classes.
Because benzodiazepines have that sealing effect.
Right. Because they are positive allosteric modulators, they possess an inherent pharmacological sealing effect. They can only amplify the GABA that the brain is currently releasing. They act as a speed limiter.
But barbiturates have no such sealing.
None whatsoever. In a significant overdose, barbiturates will autonomously force massive chloride influx, leading to profound, unchecked central nervous system depression. This results in respiratory arrest, cardiovascular collapse, and death.
The lethal to effective dose ratio is terrifyingly narrow for barbiturates. I mean, it can be as low as 3 to 1. You take 3 times your normal dose, and you could die.
It's remarkably dangerous.
Whereas for benzodiazepines, the ratio is astronomically higher, often estimated around 200 to 1. This is why, barring the co-ingestion of other central nervous system depressants like alcohol or opioids, it is exceedingly difficult for a patient to fatally overdose on a pure benzodiazepine alone.
And that ceiling effect is exactly what revolutionized psychiatric prescribing in the mid-20th century. But we must return to the structural complexity of the receptor because the specific subunits making up that pentamer dictate the clinical effects we observe.
Right, because the receptor isn't uniform across the brain, is it?
Far from it. Not all alpha subunits serve the same function. Receptors containing alpha-1, alpha-2, or alpha-3, and alpha-5 subunits are sensitive to benzodiazepines. Receptors containing alpha-4 or alpha-6 subunits are entirely insensitive.
And clinical researchers have managed to map specific physiological effects to these individual subunits, haven't
They
they?
have. The alpha-1 subunit, which is highly prevalent in the cortex, appears to mediate sedation, hypnosis, and anterograde amnesia, as well as ataxia.
And the others?
Conversely, the alpha-2 and alpha-3 subunits, which are more concentrated in the limbic system, are primarily responsible for the anxiolytic or anti-anxiety effects and muscle relaxation.
So if I'm a pharmaceutical chemist looking at that receptor profile, my immediate thought is, can we exploit this? Can we build a molecule that acts like a benzodiazepine but only targets the alpha-1 subunit?
Thereby inducing sleep without causing muscle relaxation or affecting the limbic anxiety centers?
Exactly. And that is exactly what the Z drugs are. Zolpidem, Zaleplon, Azopiclone. They are non-benzodiazepine structures that bind to the benzodiazepine site, but they display a high affinity specifically for the alpha-1 subunit.
That was indeed the theoretical design intent. By selectively targeting the alpha-1 subunit, agents like zolpidem induce rapid sedation with a significantly lower profile of anticonvulsant or muscle relaxant properties. It seems like a perfectly engineered hypnotic.
But wait, let's challenge that. Because if Z drugs are so selective, if they're only pressing the sleep button and ignoring the broader inhibitory network, why do we still see clinical reports of profound physical dependence and withdrawal syndromes with long-term Z drug use?
Because the central nervous system's drive for homeostasis is ruthlessly efficient. Even though Z drugs are relatively selective, they are still chronically amplifying the inhibitory tone of the brain.
And the brain pushes back.
Strongly. When you artificially hold down the brake pedal for months on end, the brain does not passively accept this state of enhanced inhibition. It mounts a robust, multifaceted counteroffensive.
Which brings us to the profound neurobiology of tolerance and withdrawal. What exactly does that counteroffensive look like at the cellular level? How does the brain actively dismantle its own braking system?
Well, it happens across several domains. First, within the GABAergic system itself, we observe an uncoupling phenomenon. The allosteric interaction between the benzodiazepine binding site and the GABA binding site degrades.
So the receptor essentially stops responding to the modulator.
Yes. We also see receptor internalization. The neuron physically endocytoses the GABA-A receptors, pulling them out of the synaptic cleft and into the cell body, reducing the total number of available binding sites.
Right, so it's reducing the number of altors and changing the locks on the ones that remain.
That's exactly it. But altering the GABA system is only half of the homeostatic equation. While the brain is weakening its brakes, it is simultaneously upregulating its accelerator.
And the primary accelerator in the central nervous system is glutamate.
Yes. During chronic exposure to sedative hypnotics, the brain aggressively upregulates its glutamatergic drive. Specifically, in critical regions like the frontal cortex and the hippocampus, we see increased transcription and expression of the AMPA receptor, particularly the GLO-R1 subunit.
So electrophysiological studies show that the basal activity of these excitatory AMPA receptors significantly increases.
They do.
And there's a crucial third mechanism involving calcium, isn't there?
A profound one, actually. Chronic benzodiazepine exposure induces the upregulation of L-type voltage-sensitive calcium channels in the neuronal membrane.
An increased calcium influx is a fundamental trigger for the exocytosis of excitatory neurotransmitter.
Exactly. What is fascinating from an addiction psychiatry perspective is that this exact same upregulation of L-type calcium channels is a shared downstream pathway in physical dependence on a wide variety of substances, including chronic ethanol exposure and even nicotine.
So let's synthesize this for the clinician. A patient has been taking a daily supertherapeutic dose of benzodiazepine for 2 years. Their brain has achieved a new, heavily modified, equilibrium.
Yes. Their GABA receptors are downregulated and uncoupled,
Their excitatory glutamate AMPA receptors are massively upregulated.
and their L-type calcium channels are multiplied.
The entire system is coiled like a tightly compressed spring, held in place only by the constant presence of the drug. And then the patient runs out of their prescription. Or a well-meaning but uninformed physician abruptly discontinues the medication.
And the spring snaps.
Exactly.
Without the exogenous drug providing that massive artificial inhibitory tone, the brain's profound compensatory mechanisms are instantly unmasked. The patient is thrust into a state of severe central nervous system hyperexcitability.
The subjective experience of this must be absolutely terrifying. I mean, the patient feels like their skin is crawling. They experience severe, unremitting anxiety, resting tachycardia, diaphoresis, gross intention tremors.
And potentially generalized tonic-clonic seizures. The brain is firing completely out of control because the brakes have been stripped away, and the accelerator is permanently jammed to the floor.
This is why abrupt cessation of chronic sedative hypnotics is not just uncomfortable, it is clinically dangerous.
It is malpractice. The human genome requires time to downregulate those AMPA receptors and upregulate the GABA receptors back to a natural baseline. This necessitates a slow, methodical, mathematically calculated taper.
So if the withdrawal is this agonizing and the dependence is just a biological reflex, we have to ask a fundamental question about human behavior. Why does a patient initiate this cycle beyond their prescription? What drives the compulsive seeking?
It's a great question.
I mean, if a drug essentially just puts the brain to sleep, what is the hedonic reward?
To understand the misuse liability of sedative hypnotics, we have to examine a very specific neuroanatomical circuit, the ventral tegmental area, or VTA, and its projections to the nucleus accumbens.
This is the classic mesolimbic reward pathway, right?
Mm-hmm.
The one traditionally associated with the dopamine surges caused by cocaine or amphetamines.
Exactly, but wait.
Yeah, benzodiazepines are inhibitory. Cocaine blocks dopamine reuptake, flooding the synapse. How does a drug that enhances GABA, an inhibitory transmitter, trigger a dopamine reward signal?
It achieves this through an elegant mechanism of disinhibition. Within the VTA, you have the primary dopaminergic projection neurons, but you also have local GABAergic interneurons.
And these interneurons act as constant local brakes, tonically suppressing the firing of the dopamine neurons.
Right. And it turns out that benzodiazepines exert a significantly stronger physiological effect on these local GABA interneurons than they do on the dopamine neurons themselves.
Oh, wow. So it's a double negative.
Precisely. By profoundly hyperpolarizing the GABA interneurons, the benzodiazepines shut down the local inhibitory tone. The dopamine neurons are essentially freed from their tethers.
They're disinhibited, resulting in a phasic surge of dopamine release into the nucleus accumbens.
Yes. This drug-evoked synaptic plasticity at the VTA is the neurobiological prerequisite for positive reinforcement.
But how potent is this reinforcement clinically? And if we look at animal models, how hard will a rat work to get a dose of diazepam compared to a dose of morphine?
The animal models provide a very clear hierarchy of misuse liability, actually. In self-administration paradigms, where an animal must press a lever to receive an intravenous infusion of a drug, animals will certainly self-administer benzodiazepines at rates higher than saline.
So the reinforcement is present.
It is. However, the break point, the amount of effort they are willing to expend, is markedly lower for benzodiazepines than it is for cocaine, opioids, or notably the short-acting barbiturates.
And the condition-placed preference models show the same thing, don't they? If you condition an animal to associate a specific environment with a benzodiazepine, they will show a mild preference for that environment later. But it doesn't induce that frantic, compulsive place preference seen with severe stimulants.
Correct. The preclinical data consistently places benzodiazepines in an intermediate risk category. But translating animal behavior to complex human psychopathology requires human laboratory studies.
How do you even conduct those safely?
We frequently utilize subjects with a documented history of sedative hypnotic or alcohol use disorders. They possess the experiential baseline required to evaluate the subjective hedonic value of a new compound.
Which introduces a very thorny clinical scenario for the rest of us.
Right.
Let's say a patient with debilitating chronic generalized anxiety disorder is prescribed lorazepam. At their follow-up, they tell the psychiatrist, "This medication is incredible. I feel fantastic. I want to take it all the time."
Yes, that is a classic dilemma.
How does the clinician differentiate between a patient who is experiencing the profound relief of their crippling anxiety versus a patient who is experiencing a subclinical dopaminergic euphoria?
That is truly one of the most difficult differential diagnoses in outpatient psychiatry. We rely on highly structured single-dose subjective response models using tools like the morphine benzogen group subscale of the Addiction Research Center inventory, the RCI-MBG.
And these psychometric tools are designed to isolate the subjective experience of drug-induced euphoria from baseline symptom relief.
Exactly. And the data from these studies confirms the animal models. Benzodiazepines produce higher drug-liking scores than placebos or non-sedating anxiolytics like buspirone, but they score significantly lower than classic drugs of abuse.
And within the benzodiazepine class itself, pharmacokinetic properties dictate the specific misuse liability of individual drugs. It's not a uniform class, is it?
Not at all. Pharmacokinetics are destiny when it comes to misuse liability. The speed at which a drug crosses the blood-brain barrier determines the intensity of the subjective rush.
Right, so let's look at diazepam.
Diazepam is highly lipophilic. It is absorbed extremely rapidly from the gastrointestinal tract and aggressively crosses into the central nervous system.
And this rapid onset of action is far more likely to be perceived as rewarding or euphoric compared to a drug with slow absorption and lower lipophilicity, such as oxazepam or halazepam.
Spot on. The faster it hits the brain, the higher the misuse potential.
We should also address flunitrazepam, widely known as Rohypnol. It is vital we look at this impartially, as it has immense legal and public health notoriety.
Clinically, flunitrazepam is a highly potent benzodiazepine agonist. In many European and Latin American countries, it is legally prescribed and demonstrates significant efficacy for severe refractory insomnia.
However, its specific pharmacodynamic profile renders it exceptionally dangerous when misused.
It does. It produces profound anterograde amnesia, significantly lowers behavioral inhibition, and heavily impairs psychomotor function, particularly when its effects are synergistically amplified by ethanol.
Due to these properties, it has been illicitly trafficked into countries where it is banned, such as the US and the UK, and tragically utilized in drug-facilitated sexual assaults.
Yes, because it incapacitates the victim and prevents them from forming memories of the trauma. It is a devastating example of how receptor pharmacology can be weaponized.
Truly. Now, from a demographic standpoint, the textbook outlines very specific genetic and historical risk factors that make a patient more susceptible to developing a severe use disorder with these medications.
The most prominent, robustly validated risk factor is a personal or family history of alcohol use disorder. The neurobiological overlap between ethanol and benzodiazepines is immense.
So what does the data show when we look at those specific populations?
Studies have demonstrated that when individuals with a strong family history of alcoholism, even adult children who do not themselves have an active alcohol use disorder, are administered a single dose of a benzodiazepine, they exhibit significantly greater increases on subjective misuse potential scales compared to control subjects without that genetic history.
Wow. Their nervous system is essentially primed to find the GABAergic enhancement more rewarding.
Exactly. There may be subtle inherited variations in baseline GABA receptor subunit composition or mesolimbic dopamine tone that render these agents inherently more reinforcing for this specific demographic.
For the residents and registrars listening, this is the clinical imperative. Prescribing a benzodiazepine to a patient with a family history of severe alcohol use disorder requires meticulous informed consent, rigorous monitoring, and strict dispensing limits.
You are prescribing a compound that shares massive pharmacological homology with ethanol. It must be treated with respect.
Okay, let's transition from the neurobiology lab directly into A&E. Let's discuss the clinical manifestations. When a patient presents in a state of acute intoxication, what is the clinical picture?
Because the mechanism of action overlaps so heavily with ethanol, the toxidrome of sedative hypnotic intoxication is virtually indistinguishable from acute alcohol inebriation.
So the clinician will observe psychomotor sluggishness, gross incoordination, an ataxic, wide-based gait, and marked dysarthria slurred speech.
Yes, and cognitively, the patient exhibits impaired executive function, a narrowed attention span, and profound deficits in short-term memory consolidation.
But we also see paradoxical reactions, don't we? The drugs are supposed to be sedating, but sometimes they provoke the exact opposite behavior.
Yes, paradoxical behavioral disinhibition is a critical phenomenon, particularly at specific plasma concentrations, often during the ascending limb of intoxication or as the drug is rapidly metabolized and blood levels fall. These agents can strip away cortical suppression over limbic impulses.
So a patient who is typically reserved may suddenly exhibit emotional lability, marked irritability, or overt aggressive hostility.
Precisely. And this disinhibition is exponentially magnified when the medication is combined with alcohol.
Let's examine the other side of that coin, withdrawal. We touched on the cellular mechanism, the upregulated AMPA and downregulated GABA.
Yeah.
But what does that actually look like in the clinical setting? How do we differentiate between a minor and a major withdrawal syndrome?
Well, the vast majority of benzodiazepine withdrawal presentations fall into the minor category. These symptoms are the direct physiological manifestation of autonomic hyperexcitability.
So the patient will report intense, unprovoked anxiety, profound insomnia, vivid nightmares, and irritability.
And objectively, the clinician will note resting tachycardia, diaphoresis, muscle fasciculations, increased deep tendon reflexes, and a coarse resting tremor.
And major withdrawal symptoms for benzodiazepines.
They are relatively rare, to be honest, particularly if the patient was only taking standard therapeutic doses. However, in cases of massive supertherapeutic misuse, or with particularly potent short-acting agents like alprazolam, the hyperexcitability can cross the threshold into major symptoms.
Such as frank psychosis, visual or tactile hallucinations, hyperpyrexia, and life-threatening generalized tonic-clonic seizures.
Yes, exactly.
But we contrast that with barbiturate withdrawal. The major symptoms aren't just a possibility, they are a statistical probability.
Oh, absolutely. Barbiturate withdrawal is one of the most dangerous, predictable medical emergencies in psychiatry. Let us consider a clinical vignette just to illustrate.
Go ahead.
A 50-year-old patient who has been self-administering 1,500 milligrams of pentobarbital daily abruptly loses access to their supply. Within the first 24 hours, the minor symptoms emerge: severe tremors, profound weakness, and autonomic instability.
And then the seizure threshold plummets.
Exactly. By day 2 or 3, up to 75% of these patients will experience single or multiple grand mal seizures.
And if they survive the seizures, they transition into a delirium.
Typically between the 3rd and 8th day of abstinence, approximately 2/3 of untreated patients will rapidly descend into a florid delirium. Clinically, this is indistinguishable from delirium tremens seen in end-stage alcohol withdrawal.
So they lose all orientation to time and place. They experience terrifying visual hallucinations, often microzoopsia, seeing insects crawling on the walls or their skin.
Yes, and their autonomic nervous system collapses into chaos, resulting in hyperthermia with core temperatures climbing dangerously high, leading to cardiovascular exhaustion and potential death.
Which is exactly why the textbook explicitly dictates a core rule of addiction medicine. Never, under any circumstances, wait for the appearance of withdrawal symptoms before initiating a medical taper for a patient dependent on high-dose barbiturates. By the time the symptoms manifest, the patient is already in extreme physiological peril.
It is a race against pharmacokinetics, really, and the clinician must intervene preemptively. Now, shifting back to outpatient benzodiazepine management, there is a nuanced diagnostic challenge that frequently confounds both patients and trainees.
Ah, yes. When a patient tapers off their medication and reports feeling dreadful, the clinician must accurately differentiate between 3 distinct phenomena: rebound, recurrence, and true withdrawal.
This differential is absolutely vital. Let's break them down with clinical examples. Let's start with rebound.
Okay, rebound is characterized by the rapid return of the patient's original primary symptom, but at a severity that significantly exceeds their pretreatment baseline, right?
Exactly. For instance, a patient with mild sleep-onset insomnia takes zolpidem nightly for 4 weeks. Upon abrupt cessation, they experience 2 nights of absolute intractable wakefulness, far worse than their original insomnia.
However, the phenomenon is self-limiting and rapidly resolves within a few days. The architecture of the symptom is identical to their original complaint, just transiently magnified.
Spot on. Okay, what about recurrence?
Recurrence is simply the unmasking of the chronic underlying psychiatric illness. Imagine a patient diagnosed with severe panic disorder who is maintained on clonazepam for 3 years.
The medication successfully suppresses the panic attack.
Right. Then the patient and physician decide to taper off the medication slowly and successfully. 2 months later, the panic attacks return, identical in frequency and intensity to the patient's presentation 3 years prior.
This is not withdrawal. This is the natural history of the panic disorder reasserting itself because the pharmacological suppression has been removed.
And finally, true withdrawal.
True withdrawal is the emergence of entirely new symptoms that the patient has never historically experienced, driven entirely by the neuroadaptations we discussed earlier.
So if our patient treated strictly for insomnia abruptly stops their medication and develops profound depersonalization, hyperacusis, where normal sounds become painfully loud, severe muscle cramping, and a resting heart rate of 115 beats per minute, we are observing a true withdrawal syndrome.
Yes, because the patient did not have an underlying autonomic or somatic disorder, these symptoms are purely iatrogenic.
And predicting the onset of that true withdrawal syndrome requires a firm grasp of half-lives. A drug is not just a drug.
The elimination half-life is the primary determinant of the withdrawal timeline. If a patient abruptly discontinues a short-acting agent like lorazepam or alprazolam, the serum levels plummet rapidly. The uncompensated hyperexcitability hits the brain like a hammer.
So symptoms will typically begin within 12 to 24 hours and peak in intensity by day 2 or 3.
Correct. But if they are taking diazepam,
Diazepam has a highly lipophilic profile and produces active metabolites, such as desmethyldiazepam, which possess exceptionally long half-lives, sometimes exceeding 100 hours.
yes, the drug slowly leaches out of the adipose tissue into the bloodstream. Therefore, a patient who stops diazepam abruptly might feel perfectly fine for the first 5 or 6 days.
The true withdrawal syndrome might not manifest until the second week and might not peak until day 14.
Which is incredibly deceptive for the patient. They believe they have successfully navigated the cessation only to be struck by severe autonomic symptoms 2 weeks later. This underscores the necessity of profound patient education prior to initiating any tapering protocol.
Absolutely. Let's discuss mortality and overdose next. We mentioned the vast safety margin of benzodiazepines earlier. We have a specific competitive antagonist, fluocinolone, which can rapidly reverse a pure benzodiazepine overdose in A&E. But the textbook highlights a grim, modern reality.
Yes, the pure benzodiazepine overdose is essentially a relic of the past. The epidemiological data is catastrophic right now. The CDC reports a massive escalation in benzodiazepine-involved mortalities over the last decade.
But the critical context is polysubstance misuse. In contemporary data sets, upwards of 90% of benzodiazepine-involved fatalities also involve opioids.
And the vast majority of those involve highly potent synthetic opioid analogs, like fentanyl.
Because of the synergistic respiratory depression.
Precisely. Opioids depress the respiratory drive primarily via mu-opioid receptors in the brainstem, altering the chemoreceptor sensitivity to carbon dioxide. Benzodiazepines depress overall central nervous system arousal via widespread GABAergic inhibition.
When you combine them, you attack the respiratory centers from 2 entirely different neuropharmacological vectors.
The wide margin of safety that makes benzodiazepines theoretically safe completely evaporates. The synergistic effect rapidly induces fatal apnea.
Because of this profound polysubstance respiratory depression, a clinician cannot simply taper both drugs simultaneously when a dependent patient presents for detoxification. They have to prioritize. How do we triage that neurobiological crisis? This brings us perfectly to the integration and clinical management of these complex cases.
Triage in polysubstance detoxification is governed by the immediate risk of mortality. While opioid withdrawal is subjectively agonizing for the patient, producing severe dysphoria, gastrointestinal distress, and autonomic hyperactivity, it is very rarely fatal in an otherwise healthy adult.
Sedative hypnotic withdrawal, however, carries a high risk of fatal status epilepticus and delirium.
Therefore, the physiological imperative is to address the sedative hypnotic dependence first.
So walk me through the exact clinical sequence for a patient severely dependent on both heroin and high-dose alprazolam.
Upon admission, the clinician must immediately stabilize the opioid dependence. This is typically achieved by administering a long-acting opioid agonist like methadone or a partial agonist like buprenorphine at a dose sufficient to completely suppress opioid withdrawal symptoms.
You hold the opioid dose completely static. You do not attempt to taper it.
Exactly. Once the patient is hemodynamically stable and comfortable regarding their opioid receptors, you initiate the rigorous, mathematically calculated taper of the benzodiazepine.
Only after the benzodiazepine has been completely discontinued and the patient has safely passed the risk window for delayed seizures or delirium do you even begin to consider tapering the melatonin or buprenorphine.
That sequential logic is brilliant, and it's life-saving. Now, regarding the mechanics of the benzodiazepine taper itself, the textbook outlines a few different approaches. Some clinicians will simply take the medication the patient is currently on and reduce the dosage by, say, 10 to 25% every few weeks.
But many addiction specialists advocate for a substitution protocol first. Why switch the drug before lowering the dose?
The substitution protocol is driven entirely by pharmacokinetics, aiming to prevent interdose withdrawal. If a patient is highly dependent on a short-acting agent like alprazolam, their blood serum levels are constantly experiencing sharp peaks shortly after a dose, followed by steep troughs a few hours later.
During those troughs, the brain experiences transient microwithdrawals. The patient feels spikes of intense anxiety, which kindles the nervous system and creates profound psychological distress.
It essentially trains the patient to panic between every single dose.
To circumvent this, the clinician calculates the pharmacological equivalent of the patient's total daily dose and substitutes a long-acting agent, typically diazepam or clonazepam, or in severe cases, a barbiturate like phenobarbital.
Yes. Because these long-acting agents have extended half-lives and active metabolites, they provide a smooth, continuous serum level. The peaks and troughs are eliminated.
Once the patient is stabilized on this smooth plateau, the clinician can begin reducing the daily dose by roughly 30% initially, and then proceeding with smaller, highly structured decrements, monitoring the patient's physiological response at every step.
This meticulous pharmacological management is absolutely vital. Now, before we synthesize our final takeaways, the chapter details a few older, miscellaneous, sedative hypnotics. They are rarely prescribed today, but they still appear on board exams and occasionally in A&E.
We must understand their unique mechanisms. Let's start with meprobamate.
Meprobamate was historically marketed under the brand name Milltown, and it is a carbamate derivative. It gained massive popularity in the 1950s, but has largely been abandoned due to its abysmal safety profile.
While it functions as a mild anxiolytic, its physiological dependence liability is severe. A pronounced withdrawal syndrome can manifest even when discontinuing standard therapeutic doses.
More alarmingly, the incidence of severe, life-threatening seizures during meprobamate withdrawal is reported to be even higher than in barbiturate withdrawal. Furthermore, its lethal to effective dose ratio is terrifyingly narrow. Fatalities from overdoses have been documented with ingestions as low as 12 grams.
Next is a molecule that is both endogenous to the human brain and highly notorious, gamma-hydroxybutyrate, or GHB. It gained a dark reputation in the 1990s as a club drug, but it is actually an FDA-approved medication today.
Yes, under the generic name sodium oxybate, it is strictly regulated and approved for the treatment of cataplexy and excessive daytime sleepiness in patients with severe narcolepsy. Its neuropharmacology is fascinating and entirely distinct from the benzodiazepines.
GHB is naturally synthesized in the brain from GABA via the actions of GABA transaminase and succinic semialdehyde reductase. It acts as an agonist at specific G-protein-coupled GHB receptors.
But it doesn't touch the GABA-A receptor, does it?
No, it lacks affinity for GABA. However, at higher concentrations, it acts as a direct agonist at the GABA-B receptor, which is a metabotropic receptor.
The profound euphoric and prosexual effects reported by illicit users are likely mediated by its complex biphasic effect on dopamine. It initially inhibits dopamine release, leading to a buildup in the presynaptic terminal, followed by a massive enhanced release of dopamine into the striatum and mesolimbic systems.
However, its safety margin is minuscule. When combined with other central nervous system depressants, particularly ethanol, it rapidly induces deep coma and unpredictable treatment-resistant respiratory depression.
Finally, we must mention chloral hydrate. This is one of the oldest synthetic sedatives in medical history, famously known in early 20th century pulp fiction as Mickey Finn knockout drops.
Chloral hydrate itself is inactive. Its hypnotic efficacy relies entirely on its rapid hepatic metabolism into its active metabolite trichloroethanol.
It is rarely utilized in modern practice because, at supertherapeutic doses, it exhibits profound cardiac toxicity. It directly depresses myocardial contractility and shortens the cardiac refractory period, predisposing the patient to fatal ventricular arrhythmias.
It also has some very dangerous drug interactions regarding protein binding.
A critical pharmacological flaw. Its secondary metabolite, trichloroacetic acid, binds fiercely to plasma proteins. If a patient is concomitantly taking an oral anticoagulant, such as warfarin, the trichloroacetic acid will violently displace the warfarin from the protein binding sites in the blood,
which causes a sudden, massive spike in the concentration of free, active anticoagulant, which can precipitate catastrophic, spontaneous internal hemorrhage.
These older drugs perfectly illustrate why the benzodiazepines completely dominated the market upon their discovery. Despite the risks of physiological dependence, benzodiazepines do not generally induce fatal cardiac arrhythmias, nor do they wildly displace anticoagulants.
But if we return to the patient sitting in the clinic, the patient trapped in their dependence, the pharmacology is truly only half the battle. The textbook emphasizes that the psychology of withdrawal is just as critical as the pharmacokinetics.
The psychological dimensions are immense. Patients who have been maintained on long-term sedative hypnotics often present with profound anticipatory anxiety.
They may have attempted to taper off the medication unilaterally in the past, experienced the terror of true withdrawal or severe rebound, and concluded that cessation is impossible.
They arrive at the clinic convinced that the tapering process will be an agonizing, unpredictable ordeal.
If the clinician acts purely as a pharmacist, calculating the diazepam equivalents, handing over a tapering schedule, and ignoring the patient's sheer terror, that taper is almost guaranteed to fail.
It will fail. Successful management requires robust psychological scaffolding. The clinician must utilize cognitive behavioral techniques to restructure the patient's catastrophic thinking.
They must rigorously educate the patient on the physiological distinction between transient rebound symptoms and the reemergence of their underlying anxiety disorder.
The goal is to safely guide the neurochemistry back to its basal state, while simultaneously providing the patient with the psychological resilience required to endure the inevitable discomfort of that transition.
This has been a remarkably dense, mechanistically rigorous exploration. Before we move to the learning reinforcement, let's synthesize the core mental models from today's analysis.
The foundational takeaway is the absolute necessity of separating physiologic dependence from a substance use disorder. Dependence is a predictable, inevitable neuroadaptation of the GABAergic and glutamatergic systems.
Addiction is a complex socio-behavioral pathology characterized by compulsive misuse despite devastating harm. Conflating the two is clinically inaccurate and highly stigmatizing.
Second, the safety profiles of these agents are dictated by their structural interaction with the receptor. Benzodiazepines are positive allosteric modulators. They require endogenous GABA to function, giving them a vital physiological ceiling.
Barbiturates, at high doses, transition into direct agonists, forcing the chloride channel open independently, resulting in profound lethality and overdose.
Third, withdrawal is the unmasking of the brain's homeostatic compensations. When the exogenous inhibitory drug is removed, the clinician is left managing a nervous system characterized by downregulated GABA receptors, upregulated excitatory AMPA receptors, and increased L-type calcium channel density, resulting in dangerous autonomic hyperexcitability.
And finally, successful clinical management requires a deep understanding of pharmacokinetics. We must utilize long-acting substitution to prevent interdose withdrawal. We must meticulously separate polysubstance detoxifications to prevent mortality, and we must aggressively manage the psychological expectations of the patient undergoing the taper.
Okay, let's pressure test these concepts. I'm going to present 6 clinical vignettes and single best answer questions based directly on the neurobiology and clinical management we've discussed. We will break down the distractors to ensure the reasoning is fully solidified.
Let's begin. I'll read the question, give a pause, and then you break it down. Question 1. Concept. You're evaluating a 45-year-old executive who has taken prescribed clonazepam daily for 3 years. They experience tremors and tachycardia if they miss a dose, but they have never escalated their dose, they perform exceptionally well at work, and they have never engaged in drug-seeking behavior. Which of the following criteria is absolutely required to diagnose this patient with a severe substance use disorder, but is not required to establish that they have a physiological dependence? Is it A, the development of pharmacological tolerance over time, B, the emergence of a stereotypic withdrawal syndrome upon cessation, C, continued use of the substance despite significant negative behavioral, occupational, and social harm, or D, receptor neuroadaptation at the GABA-A pentamer?
The answer is C, continued use of the substance despite significant negative behavioral, occupational, and social harm. Tolerance, which is A, withdrawal, which is B, and neuroadaptation, which is D, are all hallmarks of expected physiological dependence. They do not constitute a sociobehavioral addiction disorder.
Spot on. Question 2. Mechanism. A pharmaceutical research team is attempting to synthesize a novel anxiolytic compound. They wish to emulate the safety profile of diazepam. To achieve this, their novel compound must exert its primary effect by binding to which specific location? A, the orthosteric GABA binding site located on the metabotropic GABA-B receptor. B, the specific modulatory interface located between the gamma-2 and alpha subunits on the GABA-A receptor. C, the interior lumen of the chloride ion channel directly blocking ion flow. Or D, the excitatory AMPA-GluR1 subunit acting as an antagonist?
The answer is B, the specific modulatory interface located between the gamma-2 and alpha subunits on the GABA-A receptor. A is incorrect because benzodiazepines target GABA-A, not GABA. C describes a channel blocker, not an allosteric modulator. And D is incorrect as benzodiazepines do not directly bind to glutamate receptors.
Perfect anatomical precision. Question 3. Mechanism and safety. A 30-year-old patient is brought to A&E unresponsive after intentionally ingesting a massive overdose of secobarbital. Why is this patient at a vastly higher risk of fatal respiratory depression compared to a patient who overdosed on a similar supertherapeutic quantity of a benzodiazepine? A. Barbiturates possess a significantly longer elimination half-life, prolonging the toxicity. B. At high concentrations, barbiturates act as direct agonists, holding the chloride channel open completely independently of endogenous GABA. C. Barbiturates selectively target the alpha-1 subunit, which directly controls the medullary respiratory centers. Or D. Barbiturates fail to induce pharmacokinetic tolerance, making every dose act like a naive exposure.
The answer is B. This is the key difference. Barbiturates act as direct agonists at high doses, destroying the physiological ceiling effect. A is irrelevant to the peak mechanism of lethality. C is factually incorrect. Z drugs target the alpha-1 subunit, not barbiturates.
Precisely. Question 4. Clinical reasoning. A 55-year-old patient who has been on high-dose, long-term diazepam abruptly loses their prescription. 72 hours later, they present to the clinic experiencing severe anxiety, diaphoresis, and a resting tremor. Which specific neuroadaptive cellular changes are primarily responsible for generating this state of acute central nervous system hyperexcitability? A. Upregulation of GABA-A alpha-1 mRNA transcription and markedly decreased AMPA receptor activity. B. Downregulation of available GABA-A receptors, significant upregulation of excitatory AMPA receptors, and increased density of L-type voltage-sensitive calcium channels. C. Profound blockade of voltage-sensitive calcium channels, preventing neurotransmitter release. Or D. Severe hyperpolarization of the local GABA interneurons within the ventral tegmental area.
The answer is B. The brain has downregulated the brakes GABA-A and upregulated the accelerators AMPA and calcium channels. Option A proposes the exact opposite of what actually occurs. Option D describes the mechanism of dopamine reward disinhibition, not the mechanism of systemic withdrawal.
Excellent deduction. Question 5. Clinical manifestation. A 40-year-old patient taking zolpidem strictly for sleep-onset insomnia for 6 months abruptly discontinues the medication. The following night, they experience insomnia that is subjectively much more severe than their baseline before initiating the treatment. However, they experience no autonomic instability, and the severe insomnia completely resolves within 72 hours. This clinical presentation is most accurately described as A. Rebound, B. Recurrence, C. True withdrawal, or D. Intoxication delirium.
The answer is A. Rebound. It is the original symptom, insomnia, returning transiently at a higher intensity. It is not B. Recurrence because it resolves rapidly rather than establishing a chronic baseline. It is not C, true withdrawal, because there are no entirely new autonomic symptoms like tremors or tachycardia.
Correct. Final question. Question 6. Clinical reasoning. You are managing a 28-year-old patient admitted for detoxification. They have a documented severe daily dependence on both high-dose intravenous heroin and supertherapeutic oral alprazolam. To minimize mortality risk, what is the strongly recommended clinical approach for this polysubstance presentation? A. Rapidly detoxify the patient from the heroin first, while holding the alprazolam dose steady to prevent opioid-induced respiratory depression. B. Abruptly discontinue both substances simultaneously to prevent pharmacological cross-tolerance and expedite receptor healing. C. Methodically taper and detoxify the alprazolam first, while holding the opioid dependence perfectly stable with maintenance methadone or buprenorphine. Or D. Substitute the alprazolam with a short-acting barbiturate and taper it rapidly over 48 hours.
The answer is C. You must detoxify the benzodiazepine first to mitigate the risk of fatal seizures and delirium while keeping the opioid receptors stabilized with methadone. A is incorrect because opioid withdrawal is not generally fatal, whereas benzo withdrawal is. B is dangerous malpractice that will likely induce severe delirium. D is incorrect because substituting with a short-acting agent worsens interdose withdrawal. We use long-acting agents.
Flawless clinical reasoning. I strongly encourage our listeners to return directly to the text of Chapter 11 Pleasant to review these exact electrophysiological mechanisms and diagnostic distinctions.
It's vital reading.
Think about the concept of recurrence versus rebound we discussed. It forces us to ask a deeply philosophical question about the nature of psychiatric intervention. When we suppress a debilitating symptom for years with a powerful sedative, does the brain ever truly forget the anxiety? Or does it merely build a stronger neurobiological cage? When the medication is finally fully removed, are we meeting the original disease? Or are we encountering a nervous system that has spent years quietly, aggressively training to fight a phantom? Here are the details of this episode.
Sedative, hypnotic, or anxiolytic-related disorders. Byline. The most dangerous dependence is often the one that begins with a legitimate prescription. Based on Kaplan and Sadek's comprehensive textbook of psychiatry, chapter 11.10, sedative, hypnotic, or anxiolytic-related disorders.